Welcome back to the Metabolic Revolution podcast. I'm Dr. Steve Presciutti, and today we're delivering on a promise I made you at the end of our last episode. If you remember the close of our blood pressure deep dive, I told you the next conversation was going to blow your mind, that we were going to dive into why your gut is the hidden driver of so many of the conditions we've been discussing all season, and that something called the endotoxin connection might be the most important topic in metabolic health that mainstream medicine refuses to look at. This is that episode. If you've been told you have irritable bowel syndrome, SIBO, leaky gut, chronic constipation, reflux, GERD, fatigue your doctor cannot explain, brain fog of unknown origin, persistent low-grade inflammation, skin issues like rosacea or eczema, or any of the increasingly common cluster of symptoms that get filed under the polite phrase functional bowel disorder, this episode is for you. Quick reminder before we get into this podcast is educational content only, not medical advice. Always consult with your healthcare provider before making changes to any medication or treatment plan, particularly if you're currently on a proton pump inhibitor, an antibiotic protocol, or a prescription motility drug. This is Season 2, Episode 9, and it sits at the center of everything we've been building all season long. By the end of this episode, you're going to understand what endotoxin actually is, why it leaks out of your gut into your bloodstream, how it physically damages the mitochondria inside every one of your cells, why your gastroenterologist has almost certainly never measured it, and what to actually do about it starting tomorrow morning. Next episode kicks off a 3-part series on autoimmune disease, and everything we cover today is the soil that series grows in. Because the gut is where autoimmunity is born, and the gut is where almost every chronic condition mainstream medicine throws medication at without ever asking why. Let's get into it. So let me start with what endotoxin actually is, because this is the foundation of everything we're going to discuss for the next 40 minutes. And almost nobody knows this terminology, even though it might be the most clinically relevant biochemical fact in modern medicine. Endotoxin is shorthand for lipopolysaccharide, or LPS, and it is a fragment of the outer cell wall of gram-negative bacteria. You have trillions of bacteria living in your gut. That part is well known, and a meaningful percentage of them are gram-negative species, organisms like E. coli, Bacteroides, Salmonella, and Klebsiella. When those bacteria die, which they do constantly as part of normal gut turnover, their cell walls fragment and release LPS into your intestinal lumen. In a healthy gut with an intact barrier, that endotoxin stays exactly where it belongs, on the inside of the tube, gets bound up by bile and fiber, and exits in your stool. The problem is what happens when the barrier between the inside of your gut and the rest of your body becomes permeable, and a small but biochemically catastrophic amount of that endotoxin slips into your bloodstream. That is leaky gut at the molecular level. It is not a fringe idea. It is documented in the peer-reviewed literature under terms like metabolic endotoxemia and intestinal hyperpermeability. Now let me explain how that barrier breaks down, because this is the part the medical establishment treats as if it doesn't exist. Your intestinal lining is 1 cell thick. 1 cell. That single layer of epithelial cells is held together by structures called tight junctions, and those tight junctions are dynamically regulated by a protein called zonulin. Under healthy metabolic conditions, with adequate cellular energy and a low stress hormone load, zonulin keeps those junctions sealed. But under chronic stress, with elevated cortisol, with seed oils oxidizing your cell membranes, with poorly tolerated food proteins like gluten in some people, with inadequate caloric intake and chronic sympathetic nervous system activation, zonulin levels climb and those tight junctions loosen. The barrier becomes a sieve. Endotoxin enters circulation. And here is what your gastroenterologist is not measuring during your colonoscopy. The colonoscopy looks for visible structural damage. It can spot polyps, ulcers, tumors, and gross inflammation. It cannot see microscopic permeability. it cannot see endotoxin in your blood. It cannot see what's happening at the cellular level on the inside of that one-cell thick lining. So you get told everything looks normal, which is medically accurate at the resolution of the test and clinically meaningless to a patient whose mitochondria are being poisoned every single day. Once endotoxin gets into your bloodstream, the body responds with the most aggressive inflammatory cascade in human physiology. And this is the piece that ties everything we've covered all season together. Endotoxin binds to a receptor called toll-like receptor 4, which is expressed on virtually every cell in your body. When this receptor is activated, it triggers an immediate cascade of inflammatory cytokines, particularly TNF-alpha and interleukin-6, the same molecules that drive inflammation in arthritis, depression, cardiovascular disease, and neurodegeneration. But here is the part that mainstream completely misses. Endotoxin and the cytokines it triggers directly damage the mitochondria, the tiny organelles inside every cell that produce ATP. Endotoxin physically inhibits cytochrome oxidase, the terminal enzyme in the electron transport chain. It causes mitochondrial swelling, membrane peroxidation, and a measurable drop in cellular energy production. Remember how we talked last week about CO2 as the master vasodilator, the molecule produced by efficient glucose oxidation that keeps blood vessels open and oxygen delivered? When endotoxin damages your mitochondria, your CO2 production crashes, your blood vessels constrict, your tissues become hypoxic, your stress hormones surge to compensate. Every cell in your body, not just the ones near your gut, is suddenly doing less work with less energy. This is why a leaky gut can present as fatigue, as brain fog, as elevated blood pressure, as joint pain, as skin conditions, as anything and everything that mainstream medicine treats as separate diseases. They are all branches of the same root. Let me tell you about James because his story makes all of this concrete. James was 47, a restaurant manager working long evening shifts in the Reading area, and he had been carrying an IBS-C diagnosis, that is, the constipation predominant subtype, for over 2 years when he finally walked into my office. His gastroenterologist had run the full workup, colonoscopy, upper endoscopy, breath testing, the whole panel, and had told him the structural findings were normal. James was prescribed Linzess, a prescription motility drug, and put on a strict low FODMAP diet that had stripped most fruits and many vegetables out of his rotation. He was eating around 1,800 calories a day on that protocol. He was bloated within 30 minutes of every meal. His transit time, which we measured later with a sweet corn test, was running over 5 days, meaning food sat in his colon for almost a week before exiting. His morning body temperature was averaging 96.4 degrees. He had brain fog so severe by mid-afternoon that he was making mistakes on the restaurant's books. His face flushed bright red after every meal, a classic vascular endotoxin signature that his dermatologist had labeled rosacea and prescribed a topical for. He was drinking a daily kombucha because his functional medicine practitioner had told him to repopulate his microbiome. He was also taking 3 grams of fish oil, which I want you to remember for later in this episode. Here's what we did with James, and nothing on this list is exotic. We added fresh squeezed orange juice with a 1/4 teaspoon of salt and a teaspoon of raw honey to his morning routine. We reintroduced ripe fruit between meals, peeled apples and bananas to start, then watermelon and oranges as his gut adapted. We added well-cooked white rice and potatoes with butter to his dinners. We replaced his canola oil with butter and coconut oil. We threw out the fish oil capsules. We canceled the kombucha because the lactic and acetic acid load was further suppressing his already low stomach acid. And we started him on the daily raw carrot salad I am going to walk you through in a few minutes. By week 2, his transit time had dropped from over 5 days to 3 days. By week 6, he was having a daily bowel movement for the first time in years. By month 4, his morning temperature was 97.8 degrees. The rosacea-style flushing had resolved because the vascular endotoxin signal was gone. His afternoon brain fog had cleared. His energy was back, and he had dropped 14 pounds of inflammatory water weight. His gastroenterologist had told him he had a chronic functional disorder he would manage for life. What he actually had was a metabolic gut crisis driven by undereating, seed oils, and a probiotic protocol that was making it worse. Now let me walk you through gut motility, because this is one of the most underappreciated metabolic markers in the entire body, and it is the single fastest indicator of whether your gut is in a healthy state or a stressed one. Your transit time, the number of hours between when food enters your mouth and when it exits the other end, is a vital sign that almost no doctor measures. A healthy transit time is somewhere between 12 and 24 hours. When it stretches past 48 hours, you are in the territory of metabolic emergency, and yet roughly 20% of American adults report having a bowel movement less than once a day. The mainstream view of constipation is that it is a hydration issue or a fiber issue, neither of which is fundamentally true. Constipation is a metabolic state. It is what your gut does when your thyroid is sluggish, when your cellular energy production is low, when cortisol is chronically elevated, and when the smooth muscle of your intestinal wall lacks the ATP it needs to contract rhythmically. Slow transit means stool sits in your colon, water gets reabsorbed, making stool harder, bacteria continue fermenting, more endotoxin gets produced, more endotoxin gets absorbed back into your bloodstream through that thinned barrier, and the metabolic crisis deepens by the day. If you want one practical test, eat a half cup of corn kernels at lunch and watch for them in your stool. Under 24 hours is healthy. 48 hours is concerning. Over 72 hours is a metabolic emergency that needs to be addressed urgently, regardless of whether your colonoscopy was normal. Now let's talk about bile flow, because this is the piece that almost nobody outside of the bioenergetic community is teaching, and it is genuinely beautiful biology when you see it. Your liver continuously produces bile, which is concentrated in your gallbladder and released into your small intestine in response to meals, particularly meals that contain fat. Bile does two critical things. It emulsifies fats so you can absorb them, which is the textbook function. But more importantly, bile is antimicrobial. It actively sterilizes the upper portion of your small intestine, preventing bacteria from setting up shop where they don't belong. This is one of your body's primary defenses against SIBO, small intestine bacterial overgrowth. And here's the part that contradicts 40 years of mainstream dietary advice. The single biggest stimulus for bile release is saturated fat: butter, ghee, beef tallow, coconut oil. The fats mainstream medicine has been telling you to avoid are precisely the fats that drive your gallbladder to contract and release bile that keeps your small intestine clean. Diets that restrict saturated fat, the low-fat diets, the high polyunsaturated diets, the diets full of vegetable oils that don't provide the same bile-stimulating signal, lead to sluggish gallbladders, stagnant bile, and the perfect environment for bacterial overgrowth in the upper gut. Ray Peat understood this decades ago, and the research is now catching up. This connects directly to what is called small intestine bacterial overgrowth and small intestine fungal overgrowth, and these conditions are now being diagnosed at epidemic rates in functional medicine clinics. SIBO is broken into two subtypes by which gas the bacteria produce: hydrogen dominant and methane dominant. Methane SIBO, sometimes called intestinal methanogen overgrowth, is associated more with constipation, while hydrogen tends to drive diarrhea or alternating patterns. Mainstream gastroenterology often misses both, and even when they do diagnose it, the standard treatment is rifaximin, a non-absorbed antibiotic, sometimes with neomycin added for the methane subtype. Patients improve for 2 or 3 months, and then SIBO almost always recurs, because the antibiotic does not address why the small intestine became colonized in the first place. The why is metabolic. Slow motility from low thyroid, sluggish bile from low saturated fat intake, low stomach acid from a depressed metabolic state, and a stressed nervous system that has shut down the normal cleansing waves of the migrating motor complex between meals. fix the metabolism, restore bile flow, restore stomach acid, restore motility, and SIBO resolves and stays resolved. Without the metabolic restoration, you are running on a treadmill of antibiotic protocols forever. Stomach acid is the next piece, and it is one of the most clinically misunderstood topics in primary care. Mainstream medicine treats reflux and GERD as if the problem is too much stomach acid, and the dominant intervention is proton pump inhibitors, drugs like omeprazole and esomeprazole that suppress acid production. The clinical reality is that the vast majority of reflux patients have low stomach acid, not high, and the burning sensation comes from delayed gastric emptying, allowing the small amount of acid present to splash back upward. Why is stomach acid low? Because making hydrochloric acid is a metabolically expensive process, and when your overall metabolic rate is low, when your morning temperature is 96.4, like James's was, your parietal cells literally cannot keep up. Low stomach acid means proteins do not get broken down properly. Pepsin does not get activated. The antimicrobial sterilizing function of stomach acid is gone, and undigested food particles and surviving bacteria flood into the small intestine where they do not belong. Multiple large studies have linked long-term PPI use to increased risk of small bacterial overgrowth, C. difficile, nutrient deficiencies, and bone fractures. The drug is treating a symptom by deepening the underlying metabolic dysfunction. Now I want to talk about serotonin, because this is one of those topics where the mainstream story is so different from the actual biochemistry that it borders on medical malpractice. You have been told serotonin is the happiness chemical, the brain neurotransmitter that gets boosted by SSRI antidepressants, the molecule whose deficiency causes depression. None of that is well established by the actual data, and what is well established is something almost nobody mentions. Roughly 90% of the serotonin in your body is made not in your brain, but in the enterochromaffin cells of your gut. And serotonin in the gut is not a happiness signal at all. It is an inflammatory stress mediator, a powerful vasoconstrictor, and a potent driver of intestinal hypermotility, or, paradoxically, when receptors downregulate, hypomotility. Ray Peat called serotonin the suffering hormone, and Haidut, Georgy Dinkov, has written extensively about how elevated serotonin is associated with virtually every chronic disease state we treat. When endotoxin enters your bloodstream, it triggers serotonin release. When you eat tryptophan-heavy muscle meats without balancing them with gelatin or bone broth, you flood your gut with the precursor to serotonin. Aspirin, by contrast, lowers serotonin throughout the body and is one of the most underused interventions in metabolic medicine. But that is a topic for our autoimmune series. Probiotics are the last piece of mainstream gut wisdom I want to dismantle, because the average patient walking into a health food store and buying a 50 billion CFU probiotic blend is making a decision based on almost no real understanding of what they are doing. Probiotics are not a uniform category. There are hundreds of bacterial strains, and they have wildly different effects in different people depending on what is already living in their gut and what state their immune system is in. Some strains, particularly certain lactobacillus and bifidobacterium species, can be helpful for some people. But many commercial probiotics are packed with histamine-producing strains that make food sensitivities worse, with strains that aggressively colonize the small intestine when they were meant for the colon, or with strains that compete with beneficial native flora. Kombucha, which gets marketed as a probiotic powerhouse, is loaded with acetic and lactic acid that further suppress already low stomach acid in many patients, and it is fermented with yeasts that can drive SIFO. The deeper truth is that probiotics are downstream of gut conditions. If your gut environment is metabolically healthy, with good bile flow, adequate stomach acid, normal motility, and low endotoxin, the right bacteria proliferate naturally without supplementation. If your environment is sick, no probiotic is going to fix it. Fix the soil first. The plants follow. Now let me give you the single most useful daily intervention I have ever introduced into my clinical practice for gut health, and this is the carrot salad protocol I have been alluding to. The recipe is almost embarrassingly simple. Take 1 medium raw carrot, shred it lengthwise on a coarse grater so the fiber stays in long, thin strips, not pulpy bits. Toss it with about a teaspoon of coconut oil, a teaspoon of apple cider vinegar or plain white vinegar, and a generous pinch of high-quality salt. Eat it once a day, ideally between lunch and dinner, so it hits your gut between meals when it can do its work without competing with active digestion. Why this works is mechanical and elegant. The unique fiber structure of raw carrot, particularly when it is shredded long rather than pulped, physically binds to bacterial endotoxin in the lower gut. It also binds to excess estrogen that has been recycled back through the enterohepatic circulation, the loop where the liver dumps detoxified estrogen into bile and the gut, and a sluggish gut reabsorbs it back into the bloodstream. The carrot fiber traps both endotoxin and estrogen in its matrix and carries them out of the body in your stool. Ray Peat introduced this protocol decades ago, and Haidut has written extensively about the clinical evidence supporting it. It costs roughly 30 cents a day. It works, every day, mechanically, no supplement required. Saturated fats deserve their own moment here because they are central to gut healing, and they have been demonized for 40 years on the basis of cardiovascular research that did not hold up. Ray Peat said saturated fats terminate the stress reaction, while polyunsaturated fats amplify it, and the gut application of that principle is enormous. Saturated fats stimulate bile flow, which sterilizes the small intestine. They are not oxidatively unstable, so they do not generate the lipid peroxidation that damages your gut barrier from the inside. They incorporate cleanly into the membranes of your enterocytes, the gut lining cells, supporting healthy tight junction function. They support thyroid hormone signaling at the receptor level, which keeps the smooth muscle of your gut contracting rhythmically. Coconut oil, butter, ghee, and beef tallow should be your default cooking fats. Replacing the soybean oil, canola oil, corn oil, sunflower oil, safflower oil, and yes, the fish oil supplement in your medicine cabinet with stable saturated fats is one of the highest leverage interventions in gut medicine. Your gut barrier rebuilds itself from the building blocks you give it. Give it stable building blocks. The PUFA gut connection deserves a moment too, because this is the piece functional medicine often gets exactly backward. Most autoimmune diet protocols and most gut healing protocols recommend high-dose fish oil for the omega-3 content. The chemistry tells us this is a catastrophic mistake. Polyunsaturated fats, including the marine omega-3s EPA and DHA, are extraordinarily oxidation-prone. They contain 5 to 6 double bonds in their molecular structure, each of which is a site where oxygen can attack and rip the molecule into reactive aldehydes and other inflammatory breakdown products. When you take fish oil, those PUFAs get incorporated into your enterocyte membranes, into your mitochondrial membranes, and into the cardiolipin that holds your respiratory chain together. They peroxidize. They damage the gut barrier from the inside. They paralyze your thyroid receptors. They directly inhibit mitochondrial cytochrome oxidase, and they suppress the immune cleanup that would otherwise clear endotoxin. Fish oil and the other vegetable seed oils are the chemical engine of the leaky gut you are trying to heal. Stop the supplement. Read every label. Stress, sleep, and the cortisol axis are the next piece, and this is where we connect back to several earlier episodes this season. Remember from episode 6 on stress and epigenetics how we talked about cortisol regulating up to 20% of your expressed genome? Cortisol also directly governs gut motility through its effect on the migrating motor complex, the cleansing wave that sweeps through your small intestine between meals to clear bacteria. Chronic stress shuts that complex down. It also lowers vagal tone, the parasympathetic signaling that drives normal peristalsis and digestive secretion. And remember from episode 5 on sleep how just 1 week of partial sleep deprivation produces measurable changes in DNA methylation? Sleep deprivation also slows gut transit, raises endotoxin absorption, and disrupts the circadian rhythm of bile release. Your gut is not a separate system from your nervous system. It is an extension of it. Sleep enough. Address chronic stress. Eat in a calm parasympathetic state, not standing up at the kitchen counter checking email. Your enteric nervous system, the second brain in your gut, requires the same environment your central nervous system requires. Now let me close the metabolic loop by tying this back to thyroid, episode S2E7. We covered there how slow metabolism, low T3, and a depressed mitochondrial state create a cascade of downstream dysfunction. Apply that to the gut, and the picture becomes brutally clear. Low thyroid means low cellular energy in the parietal cells of the stomach, so stomach acid drops. Low thyroid means slow, smooth muscle contraction, so gut motility crashes. Low thyroid means sluggish bile production, so the small intestine loses its antimicrobial barrier. Low thyroid means a colder body, a slower gut, longer transit, more bacterial fermentation, more endotoxin production, more endotoxin leaking into the bloodstream, more TLR4 activation, more mitochondrial damage, more thyroid suppression. It is a doom loop, and once you see it, you cannot unsee it. The intervention point is upstream. You cannot fix the gut without fixing the metabolism, and you cannot fix the metabolism without fixing the gut. They have to come up together. Eating enough calories, getting carbohydrates from fruit and root vegetables and white rice, replacing seed oils with saturated fats, salting your food to taste, and addressing transit time directly are not separate interventions for separate problems. They are the same intervention applied to one interconnected system. So what do you actually do, starting tomorrow morning? First, eat breakfast within 60 minutes of waking every single day, with at least one source of carbohydrate, one source of protein, and one source of saturated fat. 8 ounces of fresh squeezed orange juice with a 1/4 teaspoon of high-quality salt and a teaspoon of raw honey. 3 eggs cooked in butter and a piece of ripe fruit is the simplest version. Second, do the daily carrot salad exactly as I described, between lunch and dinner. Third, eliminate seed oils completely. Soybean, canola, corn, sunflower, safflower, cottonseed, grapeseed, peanut, walnut, flaxseed, and yes, fish oil supplements. Read every label, throw the offenders out, replace them with butter, ghee, coconut oil, and beef tallow. Fourth, eat enough food. Most women need 2,300 to 2,800 calories a day. Most men, 2,800 to 3,500. Underfeeding is one of the largest hidden drivers of gut dysfunction. Fifth, address transit time directly. If you are not having a daily bowel movement, that is not a normal variant. It is a metabolic warning. Adequate carbohydrate, salt, magnesium from leafy greens and dairy, and the carrot salad usually move people from chronic constipation to daily transit within 4 to 8 weeks. Sixth, track your morning temperature. Below 97.8 means your metabolism is slow, your gut is slow, your stomach acid is low, and endotoxin is a larger driver of your symptoms than you have been told. Let me address the questions I get most often about gut health. People ask me whether they should stay on their proton pump inhibitor while they do this protocol. And the answer is that you should not stop a PPI on your own because rebound acid hypersecretion can be deeply uncomfortable. Work with a physician to taper gradually over 4 to 8 weeks while you support stomach acid production with adequate calories, adequate carbohydrate, and bitter foods like a small piece of grapefruit or a teaspoon of apple cider vinegar before meals. Most patients can come off PPIs entirely once their metabolism climbs. The second question I get is about probiotics, specifically whether fermented foods like yogurt, kefir, and sauerkraut are okay. The honest answer is that small amounts of well-tolerated traditional fermented dairy can be useful for some people. But kombucha, store-bought yogurts loaded with sugar and additives, and high-dose probiotic supplements are usually a net negative. If you tolerate dairy, a couple of tablespoons of plain whole milk yogurt or kefir a day is fine. Sauerkraut in small amounts, fine. Kombucha, no. 50 billion CFU capsule blends, almost always no. People also ask me whether the carrot salad is going to fix everything by itself, and the honest answer is no. It is one of 7 or 8 foundational interventions, but it is the cheapest and easiest to implement, so it is a great starting point. If you do nothing else, do the carrot salad daily for 30 days and watch what happens. People ask whether they need expensive testing, GI map, organic acids, comprehensive stool analysis, and most of the time the answer is no. Those tests rarely change the foundational protocol and often send patients down expensive supplement rabbit holes that never address the underlying metabolic state. Track your temperature, track your transit time, track your symptoms, and use the basic protocol. People ask whether they should be on antibiotics for SIBO, and my answer is that I rarely recommend them as first line because they almost always return to baseline within a few months. Restoring the metabolic conditions that prevent recolonization is a more durable strategy. And finally, people ask whether they can do this if they have severe constipation that has been chronic for decades. And yes, but you may need additional motility support like a magnesium-rich morning drink, well-cooked prunes, and sometimes a small dose of caffeine to stimulate the gastrocolic reflex. The carrot salad alone is often not enough for severe long-standing constipation. Here's what I want you to walk away from this episode understanding. Almost every chronic condition mainstream medicine treats as a separate disease has roots in the gut. Cardiovascular disease, autoimmune disease, neurodegeneration, mood disorders, skin conditions, fatigue syndromes, and endocrine dysfunction all share a common upstream driver, which is metabolic gut crisis. Endotoxin entering the bloodstream through a permeable barrier, damaging mitochondria across every tissue, triggering chronic systemic inflammation, and locking patients into a doom loop where the medications they get prescribed often deepen the underlying dysfunction. Your gastroenterologist is not trained to look at this. Your primary care physician is not trained to look at this. The colonoscopy that came back normal told you nothing about your microscopic permeability, about your endotoxin load, about your stomach acid, your bile flow, or your transit time. None of those parameters appear on standard medical testing, and yet they are the parameters that determine whether you feel well or unwell, whether your other organ systems function or fail, whether you age slowly or quickly, and whether your immune system stays calm or shifts into the autoimmune territory we are going to spend the next 3 episodes exploring. The gut is the soil. Almost every chronic disease grows from it. Heal the soil, and the rest of the system has a chance to heal. Ignore the soil, and no medication on earth is going to give you what you actually want, which is your health back. Next week, we begin a 3-part series on autoimmune disease, and everything we covered today is the foundation for that conversation. Episode S2E10, Why Your Body is Not Actually Attacking Itself, dismantles both the mainstream immunosuppression paradigm and the functional medicine leaky gut and molecular mimicry model, and replaces them with the bioenergetic framework that actually explains why autoimmune disease is doubling every generation, and why women suffer at 4 times the rate of men. The gut is where autoimmunity is born, and you now understand the mechanism deeper than 99% of physicians practicing today. Part 2 will cover the bioenergetic diet for autoimmune patients and why AIP, carnivore, and keto are slowly destroying you. Part 3 will cover the lost autoimmune cures, the toolkit of aspirin, pregnenolone, progesterone, vitamin K2, and small-dose T3 that physicians used for decades before biologics existed. If you want the complete framework laid out step by step, our Energy Reset Essentials mini course at biosparkhealth.com/energy-reset gives you everything for $39. It is the on-ramp to everything in the autoimmune series and beyond. Everything discussed today is educational information only. Work with a healthcare provider who understands metabolic and gut health before making changes to your treatment plan, especially if you are on a proton pump inhibitor or a prescription motility drug. Your gut is not broken. Your gut is responding intelligently to an environment that has been failing it for a very long time. Fix the environment, support the metabolism, and watch what happens. The revolution continues. You came to the right place. Let's talk.